today the topic of discussion is management of hypertension in diabetes patient, RSSDI recommendation 2022. Hypertension and diabetes mellitus are two of leading lifestyle diseases in the Indian and South Asian population that often coexist due to overlapping pathophysiological factors. Obesity, insulin resistance, inflammation, and oxidative stress are thought to be the same common pathways. Up to 50% of hypertension cases in India are diagnosed with type 2 diabetes mellitus. The recent RSSDI guidelines 2022 provide comprehensive recommendations for managing hypertension in patients with diabetes. As per the Indian guideline of hypertension 4, hypertension is defined as systolic blood pressure more than or equal to 140 mm of mercury and or diastolic blood pressure more than or equals to 90 mm of mercury. Primary hypertension is mostly asymptomatic, while secondary hypertension is due to various underlying pathologies. Uncontrolled blood pressure, despite the usage of 3 antihypertensive drugs, is referred to as resistant hypertension. Over 1 billion people suffer from hypertension globally, which is expected to rise up 1.5 billion by 2025. Up to 50% of cases of hypertension are also diagnosed with type 2 diabetes mellitus. Hypertension present as a major risk factors for heart failure, CVD, CKD, PAD, ED, and end organ damage. There is a complex cause-effect relationship between hypertension and diabetes, which predisposes to patients to increase risk of cardiovascular complications. For patients with diabetes mellitus and hypertension, 24-hour ambulatory blood pressure monitoring is recommended to maintain blood pressure targets of 120 to 120 mm of mercury. The use of an aneroid sphygmomanometer must be preferred over digital devices. However, digital machines may be preferred for home-based measurement. Blood pressure thresholds vary with age and comorbid conditions. Non-pharmacological management of hypertension in diabetes patients includes lifestyle modification may delay the need for pharmacological intervention or can complement the blood pressure lowering effect of drugs. A low sodium diet and a physical activity and a healthy diet are recommended to manage hypertension in diabetes patients. Now, the pharmacological management of hypertension in diabetes patients. ARBs are recommended as a choice of therapy, preferably in combination with calcium channel blockers to manage hypertension and its resulting complications. For combination therapy, newer calcium channel blockers like cilnidipine along with ARBs are recommended. Now, the cilnidipine is a novel, effective, and safe calcium channel blocker which is established for its renoprotective benefits. Combination therapy of ARBs with thiazide-like diuretics also reduces the risk of renal disorders. While telmisartan can be the first-line ARBs for treatment of diabetes hypertension due to its beneficial effect on fasting blood glucose and insulin levels. Alternatively, azilasartan with a similar safety and efficacy profile is also recommended. Thiazide-like diuretics can be preferred in elderly patients with existing coronary vascular disease. ACEi inhibitors may be used as an alternative to ARBs for CVD risk reduction in high-risk patients. Beta blockers may be preferred in patients with previous history of CVDs and alternative to RAS blockers in a pregnant woman. And in summary, hypertension is a strong modifiable risk factor for macrovascular and microvascular complications of diabetes. Strong evidence from clinical trials and meta-analysis supports targeting blood pressure reduction to at least 140 to 90 mm of mercury in most adults with diabetes. Lower blood pressure targets may be beneficial for selected patients with high cardiovascular disease risks if they can be achieved without undue burden, and such lower targets may be considered on an individual basis. In addition to lifestyle modification, multiple medication classes are often needed to attain blood pressure goals. Okay, thank you to all.